Okay, so hi Dr. Shanti. Today I'll just be presenting to you a case that I looked at in relation to hypertension for my clinical based discussion. Okay, so the patient we had was Mr. DT. So he's a 52-year-old Caucasian male. Okay, and he presented with a 3-month history of headaches, dizziness, blurred vision, fatigue, and shortness of breath on exertion. He reported that these symptoms were most commonly occurring in the morning time, and he had some other concerns based on his age and other risk factors, okay, which we'll discuss. So the first thing we wanted to investigate in relation to the headaches was we wanted to make sure that he had no other related cardiovascular, reasons that were causing this. So we did discuss with Mr. DT about any chest pain, which he said he didn't have, and any sort of syncope or arrhythmias. So this helped us rule out other conditions like angina or arrhythmias. We also discussed with him how his caffeine intake is and his sleep patterns. So he did report that he was sleeping well and that he didn't have any excessive caffeine intake, which helped us rule out sleep deprivation and caffeine-induced headaches. So regarding Mr. DT, his most common, significant risk factors was that he had family history of stroke. So his father passed away at the age of 60 from stroke, and his mother also had type 2 diabetes. Okay, so these factors could have contributed to his high blood pressure. He also had a BMI of 31, which is categorized as obese. So again, that could have been another risk factor. And he also reported to have a generally poor diet and lifestyle, so not active, not much exercise at all. He's also a smoker, so he reported 10 cigarettes per day was his normal habit, with around 15 units of alcohol a week. And as we know, both of these things could contribute to his overall cardiovascular risk and blood pressure. He also was worried that the family history was also a main contributing factor. Mm-hmm. So when we took his blood pressure reading, we got 2 readings, so 168 over 103, and then we also received 164 over 102. So
was it last week?
Sorry?
Last week?
164 over 102 was the other reading. So these fall under stage 2 hypertension. So we wanted to, so we waited 5 minutes before we took the second reading just to make sure we had a bit of a more accurate result. We offered Mr. DT ABPM, blood pressure monitoring, just to make sure that the high readings weren't caused by white coat syndrome at all. So that again confirmed to us that he did have high readings in the ABPM as well. So that helped us be reassured that he did indeed have hypertension. We also looked at secondary causes that could have been contributing to the blood pressure. So we did a blood test for Mr. DT, and we looked at his renal function, his thyroid function, and his HbA1c levels. So he had his thyroid functions was all normal, and so we weren't worried about hypothyroidism at that point. And his HbA1c was 47, so very, very borderline. So we did give him advice on that, and we did advise him that these are risk factors for cardiovascular disease and hypertension. But generally, we weren't worried about anything else. It was very straightforward, his readings were normal. So then we went into discussing treatment options. So we looked at it from pharmacological and non-pharmacological point of views. So we advised him to reduce smoking cessation. We advised him to cut down on alcohol and just adopt a more healthy lifestyle in general. And He was started on Ramipril 2.5 milligrams once daily.
2.5 you said.
2.5 milligram, yeah. So that was according to the NICE guidelines because he didn't have diabetes and he was under 55, so that was the first choice treatment option. We did also advise about healthier diet as well. You mentioned that he eats a lot of processed foods, so that's something we looked at. And then we also advised him to come back in 2 weeks' time to have his blood pressure checked again. And then we do all the necessary blood tests to make sure that the treatment was not, harmful in any way.
So how did you come to the conclusion that it's primary anyway?
So
they call it like essential hypertension as well.
Yeah. So we looked at other potential causes, but nothing seemed to. He didn't have any, cardiovascular health issues or anything when we checked his chest. So we
excluded the secondary causes.
We excluded secondary hypertension as a cause, and then we'll keep on monitoring him as well, just to make sure that nothing develops.
Well, that's good, but the other thing is that you talked about short of breath at the beginning.
Yeah.
Now, when you give the Ramipril or any ACI inhibitors, they tend to get chronic cough as well.
Yeah.
So you don't want to make this already short of breath symptoms worse.
Absolutely.
So it's better to tell the patient more about the cough and everything.
Absolutely. So we did counsel the patient on that particular symptom, and we did say that if it does occur and cause them any issues, they can have it switch. They can switch the medication over to something like losartan, which wouldn't have that particular side effect. So that was something that definitely the patient was counselled on.
Yeah, so this patient is concerned that the alcohol and this lifestyle has to change. Otherwise, the medication itself is going to work, not going to work.
Yeah, so we did emphasize on the importance of cutting down. So he was referred to a smoking cessation clinic.
Do you think we'll be able to listen to you?
Well, we're hoping. So we tried to. We didn't want to just give him the information without explaining the reason behind the advice. So we tried to connect with him on a very personal level and give him the advice in a way that would encourage him to adopt it.
And cholesterol as well.
So he is on atorvastatin 20 milligram, which is he's been put on just for primary prevention of cardiovascular events because of his family history. But that's definitely something that will be kept an eye on with the regular blood tests that will take place to make sure that the levels stay.
Why did you choose the Ramipril or ACE inhibitors?
So Ramipril, we based our decision solely on the NICE guidelines, NG 136 guidelines. So because he's under 55 and he's got, he doesn't have diabetes. He's pre-diabetic, but he doesn't have diabetes. So we opted for, and he's Caucasian as well. So we opted for Ramipril, ACE inhibitor, but we went for Ramipril 2.5 milligram as a first choice.
It's an individual choice. One of the customers certain things, different things. According to their experience as well. So Ramipril is that's why I've seen now a lot of doctors are prescribing now. The ACE inhibitors.
So
whenever you explain to the patient about the side effects, mostly like cough, isn't it?
Absolutely, cough is. We did also discuss other potential side effects. So we did tell him if he experiences any symptoms like lightheadedness, dizziness, it could mean that his blood pressure is dropping too low. So we did also counsel him on that to make sure that his blood pressure is not dropping lower than we want it to be.
And ACE inhibitors is good as well. Say, especially in renal complications, you get protein urea and all. It reduces the
absolutely. Yeah.
As well.
Yeah, so we also considered it from the renoprotective aspect. So ramipril it's got renoprotective properties. So we did also, that was also a contributing factor to our decision. And we also looked at it from a cost-effective point of view. So we looked at, ramipril, for example. It's more cost-effective, and it also provides other cardiovascular protection as well. So, a lot of studies have shown that ramipril offers cardioprotective properties on top. So it was a sort of a holistic approach to the decision, and we wanted to ensure that the patient would receive the best outcomes from the medication. Because we wouldn't want to start him on a medication that would then, if he didn't experience enough benefit from it, it might cause issues with him taking it regularly. So in order to ensure that he would continue to take it as prescribed, we had to sort of explain to him the benefits of
so if the patient returns in 2 or 3 weeks or 2 months time with a cough, whatever the alternative will be give?
So in terms of alternatives that were discussed, we'd probably go for a ARB, so angiotensin receptor blocker, something like losartan, which would work in a very similar way, but wouldn't have that particular side effect of the dry cough associated with it. So that's definitely the most close alternative that we go for in that case.
That's very good, yeah.
Okay.
Well, now.
Okay. Thank you. Any other questions?